way with a health professional, a mental health professional who can structure the talk for a particular topic. So as an example, we might have an evening around comfort eating, and everyone comfort eats. But sometimes we comfort eat to an excessive level that it starts to really impact upon our ability to manage our weight effectively. But there'll be various triggers that lead to someone to comfort eating. It might be boredom. It might be late night snacking by being at home with nothing to do, and then the availability of the food in the fridge and the pantry. It might be a coping strategy for stress or depression or anxiety or being tired, you know. So there's a lot of reasons why we comfort eat, and everyone will have their own story. And these support groups do provide an opportunity for people to share their story if they want to, or just listen if they don't, but then derive some solutions for and strategies for managing that, to put that comforting in its place so that we can then move forward in a more successful way and get the best out of our surgery and not be held back by some of those issues not being addressed properly.
Yeah. That's really good. I can see the value in that, and having it well moderated, that people aren't getting the wrong information or
Right, exactly.
Yeah.
Yeah.
Now I saw, I'm pretty sure it was on your website or somewhere, you've performed more than 10,000 gastrointestinal weight loss procedures in your career.
Yes.
That is incredible.
That's what I do. I've made it my life's work. And ever since 2004, I've been in this space. And the majority, I'm an upper gastrointestinal surgeon by training. So that means a surgeon with specific experience and training and qualification in dealing with the upper part of the gastrointestinal tract. So the esophagus, the stomach, the liver, the pancreas, the gallbladder, and the small intestine. So that's my specialty. Now, within that specialty, we have three divisions. The first division is what we call esophagogastric. That's usually dealing with cancer of the esophagus and the stomach. Another division is hepatobiliary. So that's dealing mainly with issues to do with the pancreas or the liver. And that, again, often is to do with cancers in those organs. The third division is my division, and that's bariatric surgery. So bariatric metabolic surgery, that's what I've done as my subspecialty in upper gastrointestinal surgery. And we love it. And that's why we do what we do. One of the things that I really attracted me to this specialty was the way that we can profoundly change a person's life in so many facets: their physical health, their mental health, their quality of life, their longevity, with one procedure. If you think about it, that's pretty cool, because most of the time in medicine we'll deal with a certain pathology. Let's say it's knee osteoarthritis, and so you'll go off to the knee surgeon. The knee surgeon will recommend a joint replacement and will fix that knee pain, and that's great. So one problem, one solution. And the same is true for all the other specialties. If we have a problem with a blockage in our heart, we go and see the cardiologist or the cardiothoracic surgeon, and we either have a stent placed across that blockage or a bypass around that blockage, and that fixes that one problem. But in this specialty of bariatric metabolic surgery, we have one procedure that fixes a whole range of problems at the same time. And as I mentioned before, not just the physical ones, but also the quality of life ones, which are if not equally important, possibly even more important. And it becomes very much transformational and life-changing for our patients. And that, as a doctor, is very engaging and makes us want to do what we do.
Yeah. So do you have a favorite procedure?
At the moment, I really enjoy what we call the revisional work. So revisional is dealing and correcting problems that have arisen from previous surgery. So I really enjoy that because, as well as achieving all those things we just talked about, it also helps achieve a more dramatic end. So I'll give you an example. If we've got someone who comes to me and says, I've got reflux, I've had a sleeve gastrectomy a few years ago, I had a little bit of reflux soon after the sleeve was done, but it's really worsened in the past 6 months. And I'm now to the point where it's affecting my sleep at night. I'm on maximal medical therapy to try and reduce the acid, but it's still not really holding. And I'm waking up at night time, particularly with coughing or choking or pain in the chest or hoarseness of my voice and all those symptoms that can go along with bad reflux. And what I really enjoy is being able to fix that up. And then the very first thing I ask when I come around the next day and see the patient after their corrective surgery is, how was your night last night? And it gives me a real kick when the patient says, it's the best night I've had in 6 months. That's what we like to do. So that's my favorite at the moment, is dealing with fixing problems and issues that have arisen from previous bariatric surgery. And we call that revisional surgery or corrective surgery.
Yeah.
I do a lot of that now. That'd be about 50% of my practice now would be dealing with issues like that. One common issue is some weight regain after previous surgery, and talking about options there, whether it's converting from a sleeve gastrectomy to a gastric bypass. And I offer all the different options, including the one anastomosis gastric bypass, the Roux gastric bypass, the Sadie gastric bypass. There's a lot of different types of options out there for patients. And so helping patients by converting from one form to another and re-engaging them within multidisciplinary support to get the weight back under control is also a very rewarding area of the work that I do now.
Yeah. So there's lots of options, really, isn't there? It's not just like sleeve or bypass. Uh, there's quite a few different.
There are a lot of options, and that's an important message to get across to patients. I think that there's not one method of treating this that works for every single patient. Every patient is an individual and needs a customized approach. And we have lots of options that we can use to approach how best to manage the weight. But I think the other big thing is that sometimes patients feel like as though they've been a failure if they've had some weight regain after previous surgery, and they're reluctant to come forward. They're embarrassed, and they feel shame, and they haven't been able to implement the lifestyle changes that have been recommended, and they put all that on them. And I constantly remind those patients, hey, listen, it's not your fault that you've got this weight problem, because this is genetic. You were born with those genes. You didn't ask to have those genes that predispose you to having a high level of weight and a harmful level of obesity. So it's not your fault you've got this. It is your responsibility to manage it, but it's not your fault. And it's a big, important distinction. It's your responsibility to manage it. And that's what you're doing by coming forward. But it's not your fault that you've got these genes that want you to be overweight. And these genes will be with you for the rest of your life. And so across that lifespan, we're going to need to keep treating this. We're going to need to look at different interventions at different time points in your life to get a handle on that management, better handle on that management. So you've had a sleeve 10 years ago. You did really, really well with that in the first few years. There's been some weight regain in the more recent times. That's okay. We just need to deal with it. That's almost an expected outcome for the biology of your disease. We can't imagine that one sleeve 10 years ago was going to solve permanently and cure your weight problem for the rest of your life. That's just magical thinking. That's not reality. That sleeve was a very important tool in waging the battle against your weight back then, and it remains an important tool now, but it has become blunt like any tool. It's stretched a little. The portion control is not as good as it was in the first few years. The hunger suppression may not be as good as it was in the first few years. And we need to have a sit down now and see, how do we move forward and re-establish that portion control and re-establish that hunger reduction. And at the same time, have a look at the lifestyle and the dietary behaviors and see what things we need to do to tweak that to get the best possible outcome to manage your underlying chronic medical condition. So don't be embarrassed to come forward if there's been weight regain. It's an expected thing, and it's expected that we'll then have a look at our treatment options that we have. And they may mean using some of the medication as the first step. It might be, let's build upon the sleeve by using some Mounjaro and see how we can get the control that way. Or it might be around tightening up some of the dietary misconceptions or things. Or maybe we have slipped into drinking too much alcohol without realizing the calorie value of that alcohol and the way it's sabotaging our endeavors to control our weight. So we need to have a look at all of that. We might need to change angle and move from the sleeve over to the gastric bypass, where we can get a more enhanced about a metabolic effect and a more powerful suppression of our appetite and our hunger. It might mean having a look at the sleeve itself and seeing if we need to tighten that sleeve up. It may have expanded too much, and we have tests and things that can work out the size and shape of your sleeve and whether there be any value to you by having that redone or tightened up. So there's a lot of options for patients who have got weight regain after previous surgery, whether it's a sleeve or a gastric band.
Wow. Yeah. And isn't the CT Fizz, oh gosh, after having a sleeve and then, oh, here's a can of Coke, drink the whole thing. I had one just a couple of months ago, and
Yeah.
my goodness, the pain. It's just like,
Yes.
But yeah. Do you remember your the first weight loss surgery that you performed?
I do. Back when I started doing this, the most popular procedure was the gastric band. So back in 2004, when I did my first weight loss procedure, that was the most commonly performed procedure. And so I do remember that. And I remember the one thing the gastric band did lent itself toward was regular contact with your patients after surgery, because patients would need to come back physically to see you to have the band adjusted. The band was an inflatable device. It was put in around the stomach empty, and then after the swelling of the surgery had all settled down, we would then start to inflate the band, and we would titrate the band size to the amount of hunger control the patient was experiencing and the amount of portion control they were experiencing, while at the same time not wanting to go too far that were causing vomiting or regurgitation or reflux. So there'd be an opportunity on a regular basis, once a month, to see your patients after the surgery and see how they were getting on and going, and offer them that band adjustment. At the same time, they became engaged with the clinic, and they would also come and see the dietitian and the psychologist. And so it was an opportunity for providing them with well-rounded multidisciplinary care, in addition to the focus or the reason for the presentation being the gastric band adjustment. So the gastric bands were a big part of weight management back when I started in 2004, and it remained that way really until around 2010. And the band was certainly one of the things we liked about it was very safe. The insertion of the band was associated with very, very, very few risks, if any, and it could be removed. So the safety and the reversibility of the gastric band, combined with the opportunity that the adjustments provided for enhanced multidisciplinary extended care, made it a very good device if used the right way. Now, with any area of medicine, as time goes by and there's advances in technique, advances in understanding of the underlying disease process, then we have improvements in our management. And so the big improvement that really came in the last 15 years was the sleeve gastrectomy. The sleeve gastrectomy was first done, of course, about 25 years ago, but really we needed to see a bit of track record before that started to become something we adopted around the world in big numbers. But certainly in the last 15 years, the sleeve gastrectomy has been adopted in very big numbers around the world, as more and more studies have shown it to be safe with really good weight loss. And one of the things that we like about the sleeve compared to the band, which has led to the band sort of being replaced by the sleeve, is that there's very little vomiting or regurgitation with the sleeve. as opposed to the band. With the band, if we forget to chew well or if we eat a bit quickly, then we can get blockages and then regurgitation of those food particles. And that's because everything that we eat would have to go through a narrow zone where the band was around the stomach. And that narrow zone was only around the diameter of your little finger. So if we were eating something that was bigger than that or too quick, then it will get caught in that little narrow spot. With a sleeve, it's entirely different. Rather than having a narrow spot, we just have the entire stomach volume is reduced in capacity. So rather than having a stomach volume of, let's say, 1.5 litres, after we reduce it with a sleeve gastrectomy to down to around 200 mils. So that's approximately a cup of food. But there's no narrow area in the sleeve gastrectomy. So that means that we don't have that problem of blockages and regurgitation that we had with the bands. That was a really big breakthrough of our weight management. We also eliminated all the problems that can happen sometimes with having a man-made device in your body. So the band could occasionally slip, or it could work its way through from the outside of the stomach to the inside of the stomach, called an erosion. Or the tubing connecting the band to the port could disconnect, or the port under the skin could move around. So all those device-related problems were eliminated by having the sleeve gastrectomy, which is just your own stomach made smaller without having an implanted device around it. So those breakthroughs are typical in medicine over the decades, and it happens with every facet of medicine that we have improvements over time. And as we've moved forward beyond that, we've had further improvements around the gastric bypass, and in particular, a form of gastric bypass called the one anastomosis gastric bypass, the OAGB, which has been a real breakthrough in improving and refining the previous bypass that was commonly performed, which is called the Roux-Y gastric bypass. So we loved with the Roux-Y gastric bypass the effectiveness for weight management, particularly around diabetes. But what we didn't love about the Roux-Y gastric bypass was the problems associated with the intestines getting herniated or caught up or obstructed around that second lower joint in the middle of the abdomen, and the dumping syndrome that some patients would get. So the one anastomosis gastric bypass provided us with a means of having the weight control and the diabetic control that we loved with the Roux-Y bypass, without the issues of the internal hernia and the bowel obstructions and the dumping syndrome that we hated with the Roux-Y gastric bypass. So again, that's another example of the evolutions that occur in medicine as we move toward a better way of treating what is a chronic disease process.
Wow. It's really come a long way.
It continues to. And as we see now better medications that suppress appetite and stimulate metabolism, like the Mounjaro, where there's more of these medications in the pipeline. The Mounjaro is different to the Wegovy and the Ozempic in that we call the Mounjaro a dual agonist. So in other words, the one molecule binds to two different types of receptors in our body, the GLP-1 receptor and the GIP receptor. And that's an advantage. Whereas the Wegovy and the Ozempic, they only bind to one receptor, that's the GLP-1 receptor. And there are future medications in the near-term pipeline that will bind to three receptors and therefore have an even stronger effect on appetite and on metabolism. And what we're now all moving toward is the combination of medications and surgical procedures to get the weight better managed. So we talk now about not just multidisciplinary care meaning care with dietitians, psychologists, exercise physiologists, and surgeons and physicians. That's multidisciplinary care. But multimodality care means using a combination of medications and surgical procedures to help patients get a better control of their weight.
Yeah. Because that's I guess the focus that we have to keep is that it is about the patient and their health, and I guess making it as easy as possible for them to manage their weight.
That's exactly right. And as healthcare professionals, that's what we're here for. That's why we choose to be doctors. That's why we choose to do medicine, is because we want to treat disease and help patients. And this is, and all these advances that we've been talking about are enabling us to do that more and more effectively.
Yeah. Something that we do get asked a fair bit, and I just like to get different perspectives on it, around the importance of the pre-op diet, and I guess even the post-op. People can struggle with the pre-op, especially so much with with shakes
Yes.
and all those textures. I realized for me that I have a thing with texture, and I think that's really what affected me the most was just that mouth feel and
Well, let's talk about that. So, first of all, why do we do a pre-op diet? And is a pre-op diet necessary in everyone? So, the reason why most bariatric surgeons ask our patients to have a preoperative diet before their surgery is to reduce the size of their liver. So, when we carry too much weight, the extra fat tissue is everywhere. It's under the skin, it's around our intestines, it's around our organs, but it's also in our organs. And one organ in particular that likes to really carry a lot of that extra fat tissue is the liver. And we call that fatty liver disease. And another name for that is NASH, non-alcoholic steatohepatosis. And as a result of carrying extra fat within the liver size swells. It becomes large, and it becomes larger, heavier, and more fragile. And the reason why we like to shrink that, at least in part, before we do these surgeries, is for one simple reason, and that is that the liver happens to lie over the top of the stomach. If the liver was down somewhere else in the body and nowhere near the stomach, we wouldn't be worried about the size of the liver one bit. It's just because of the fact that the liver and the stomach organ are very close together, and the liver being on top of the stomach, and we need to lift that liver off the stomach to be able to see the stomach and operate on the stomach organ. That's the reason why we like to shrink it down before surgery. But the size of the liver usually relates to the size of the patient. So a larger patient will have a larger liver, generally speaking. Not always, but generally speaking. Therefore, the amount of preoperative diet or the duration of that diet will depend in part on the patient's body mass index. The higher the body mass index, the longer they will need to do that diet to be able to address the fatty liver. So, for instance, in my practice, we don't ask our patients with a body mass index under 40 to have any preoperative diet at all, because at that body mass index level, we don't normally get to find that the liver is too much of an obstruction or an impediment to the access to the stomach at surgery. But over a body mass index of 40, we find that the livers are starting to get a bit big, and that a 2-week course of a very low calorie diet will shrink that fat out to a sufficient degree that we can then safely get the access that we need to the stomach. So generally speaking, 2 weeks is enough. In very large patients or in patients that are known to have very severe fatty liver disease, we might use a longer very low calorie diet than 2 weeks, but it's uncommon. And when we say a very low calorie diet, it doesn't have to be liquid. It just has to be very low calorie diet. So it's a diet that can be either defined as an individual thing by your dietitian who's experienced in this. And it will be typically something that's low in carbohydrate, high in protein, and low in overall calories. But it could be something like a meats and vegetable diet for 2 weeks. It could be something that's based around yogurt, or for convenience and simplicity, there are commercially available preparations such as OptiFast and OptiSlim that do have that ability to shrink the liver down. And they're nice and easy because you can get them off the shelf and don't have to think too much about it. It's only just for a 2-week period anyway. So rather than having to have a real, structured 2-week sort of diet to get the liver down, it's just easy to have one of those OptiFast shakes or bars or soups each mealtime. and to get that liver under control. So that's just to really explain why we have preoperative diets. It's just for that reason. Now, post-operatively, it's totally different. The reason why we have a specific set of instructions for diet immediately after surgery is because we want the swelling and the spasm in the stomach and the esophagus to settle down before we start eating regular normal food again. So whenever we do surgery, and I give patients the example of ankle surgery, because you can see your ankle. If you had ankle surgery yesterday, you can imagine today it's going to be very swollen. And it'll be swollen for probably the next 10 days, 2 weeks. The same thing happens internally. We just can't see it. So when we have surgery for a sleeve or a bypass or to convert from one to the other, or with a hiatal hernia repair or any of those operations in the esophagus or the stomach area, there will be swelling for several days afterwards. And so that we can get our adequate nutrition and hydration in, but at the same time not put any excessive forces or pressure on that swollen area, we need to have a liquid diet. So it can be liquids of any sort. So it can be hot, it can be cold, it can be caffeine, you can have your cappuccino, it can be with flavor, it can be with milk products, it just has to be runny. That's all. So it's not about the liver anymore. It's about having a diet that provides us with adequate hydration, adequate multivitamins and nutrients, and adequate fiber, but all of that in a form that's not going to hurt the stomach when it's been freshly operated upon, and it's going to be able to slide through the area despite it all being swollen and congested. But then as that swelling subsides, we can start to up the texture. So typically after 2 weeks, we move on to include purees. So things like scrambled eggs and yogurts and blended things to increase the range to get the protein in and get the multivitamins and the fluid and the fiber in.
Yep.
And that's just also a limited period of time. So that's for another 2 weeks. So generally after we've completed that 2 weeks of liquids, 2 weeks purees, we are then in a position to now move back on to regular, everyday, normal food. And that's where we want to be then for the rest of your life. We don't want to be having shakes. We don't want to be having blended food. That's a very, very limited time only in the early recovery after these esophagogastric operations. And the reason is so that we can allow the area to heal, allow the swelling and the spasm to settle down before we go back onto everyday solid textures.
Yep. So what about for people that are, when I had my sleeve, I was on 25 tablets a day. And I really struggled taking that many tablets after my sleeve. What is sort of recommended now that happens for people that, might be on quite a few pills?
Yeah, it's a good question. And I think the first thing is to see what pills are essential and which ones are not essential. Because there are a lot of medications or tablets, even non-prescription tablets like vitamins and things that patients are taking in their everyday life, like fish oil, for instance, that are things that we can safely and temporarily put on hold.
Yep.
And I think if we sit down and have a look at the 25 tablets that you're on, for instance, as an example, we might find that half of them are essential and half of them are not essential. We can stop those. So that depends. Yeah, that's a medical thing. We need to have a look. There's some medications, for instance, metformin, that if that's used for insulin resistance, that can be safely stopped.
Yep.
And in a lot of cases, the insulin resistance improves anyway with the weight loss, and we might be able to stop it and stay stopped. Other medications are important to continue. So, for instance, if we are on aspirin or clopidogrel because we've had a coronary stent, we can't stop those ones. If we're on blood pressure medication and the blood pressure is still very high, we can't stop those medications. So there are some that are essential, and there are some that are essential but not. But that can be safely stopped for a short period of time. And there are some that are not essential and can be safely stopped and stopped for good. So that's the first thing. The second thing is to see, okay, well, we might spread out through the time of the day that we're taking the remaining tablets. So rather than trying to take all 6 in one mouthful at one go in the morning when we first waken up, we might space it out and get those 6 tablets in over the course of a couple of hours. with the fluids that we're drinking during the early recovery phase, so we can still get the medication in, but it's one at a time.
Yep. Yep. Right. Um, yeah, I tried to swallow all of them at once the day after surgery,
In that
like
one.
I'd always done, and that was the last time I ever tried to do that. But yeah, it sort of hits you hard when you don't really think about that. Um, now another big question, uh, smoking
Yep.
and vaping.
Hmm.
Um, yeah, what are the recommendations? And it's such a hard one for people because it is addictive, and yeah, but there's got to be that level of safety when you're having surgery as well.
Absolutely. So very, very good question. We get this asked a lot. In a nutshell, smoking cessation is desirable prior to an anesthetic, but it's certainly not mandatory that we stop smoking right before an anesthetic. In fact, if we're going to stop smoking, we're better off stopping it a few weeks before the anesthetic, so we get the opportunity for the lungs to improve and to be at their best in preparation for the anesthetic. There's not much value in stopping the day before, because the lungs are no better in just a matter of a few hours. So smoking and anesthesia is not as dangerous as maybe has been painted out to be. There are plenty of patients that smoke right up to the day of surgery and have no issues with their anesthetic. But every medical practitioner will tell you, and quite rightly so, that smoking is a risk to your health and should be reduced, if not stopped, if you can at all possibly do it. And especially when you think about what we're trying to do with weight management, is we're trying to restore health. We're trying to improve longevity. And it doesn't sort of make a lot of sense to be throwing all those resources at the weight but leave the smoking unaddressed, because the smoking is the other major cause of premature death and disease in our country. The leading two causes of early death are obesity and smoking. So it doesn't make a huge amount of sense to focus all our efforts on fixing one and completely ignore the other.
The other,
So from that point of view, smoking cessation, or at least reducing your smoking, is a good idea. But we acknowledge at the same time, like you've touched on, that smoking is an addiction and it's hard to give it up. And when we have patients that may also be facing an addiction to calories or to sweets or to ice creams or chocolates, we're almost asking the impossible to say to our patients, you've got to give up two addictions at the same time. So there has to be a level of balance around what we can achieve and what we can't, and maybe a bit of a game plan around, okay, well, look, the smoking is a risk to your health. Let's have a game plan around approaching that over the next 12 months. Let's start by getting the weight under control. Let's get that underway. Let's try and reduce the smoking. But I would not be supportive, for instance, of mandating that every single smoker stop their smoking before they can have a surgery, because there's just no robust evidence in the medical world to support that rigidity. You can have your surgery and still smoke. But there are a couple of notable exceptions, and that is the gastric bypass, meaning the Roux-en-Y gastric bypass and the one anastomosis gastric bypass. Those two types of gastric bypass involve a surgical join between the stomach organ and the small intestine. That surgical join, one of the risks that can happen down the track with that joint is you can get terrible ulcers on it. Those ulcers are called a marginal ulcer, and smoking is a major risk factor for developing those marginal ulcers. These don't happen with the sleeve gastrectomy, and they don't seem to happen with the other type of bypass that I do, the SADE bypass, because those two operations, the sleeve and the SADE, do not have that specific joint between the stomach tissue and the small intestine tissue. So in my practice, if you're a smoker, I won't let you have the OAGB or the Roux-en-Y bypass. until you've stopped smoking for good, and we can be confident around that. And that's true for vaping as well as smoking. They're equally bad for the risk of ulcers. But you can certainly have a sleeve gastrectomy. You can certainly have a satiety bypass. The smoking won't adversely interfere with those two types of weight loss surgery. So it just then comes back in those patients to what are our overall goals of treatment here? If we're trying to extend your life, if we're trying to improve your medical health and prevent the onset of further medical problems on the track, we need to know what our risks are, our threats are. One of them is your weight, one of them is your nicotine intake. Let's deal with both.
Awesome. I love it. It's to me it sounds well balanced. Because I mean I haven't ever smoked myself, but I've got family that do, as most of us do. And so they really struggle coming up to surgery. And it's not that they don't want to stop, it's just that for some people and then you add all the pressure of actually, I'm having a surgery, and for some people it's the first time they've ever been under an anesthetic. And so we're asking them, stop smoking, go on shakes, can't eat anything for 2 weeks before, and then come in for this terrifying surgery that you're scared, and I think, yeah, for some people that is just would feel almost impossible.
I agree. And I think that's right. We need to break down the barriers to effective treatment, and we need to be guided by what's real hard evidence. For instance, the association between smoking and ulcers on those two types of gastric bypass, and what's just a feel good kind of idea,
Mm,
which we need to make sure that we're not getting, as medical practitioners and providers, we're not getting too caught up in uh, um, creating a lot of rigidity to our patients around what's just a feel good idea. Because we have plenty of patients who smoke right up until the day of surgery and beyond to have a sleeve gastrectomy with absolutely no problem.
yeah,
And in fact, there's one little tiny blessing in disguise about our smoking patients, and that is that it gets them out of bed after their surgery. Because one of the very important things with recovering from surgery is early mobilization. So
yeah,
smokers get out of bed and they walk outside the hospital and they have a cigarette outside the hospital, because you're not allowed, of course, have a cigarette anywhere inside the hospital
yeah,
campus. But that gets them mobilizing. It reduces their risk of blood clots in the legs. It helps to ventilate their lungs properly. So it actually is a good thing for getting patients out of bed. And so I share with you the idea to be balanced and sensible and have a sensible approach. And by all means, as a medical practitioner, identify and educate your patient about the sort of things that they may be doing that are potentially harmful to their health and harmful to their
mm,
longevity, and sort of get them really focusing on having a management plan around dealing with those things when the time is right, but not to have that rigidity that puts too much on to change onto patients all in one go.
yep, yep. I love that. When it was about 3 months before I had my gastric sleeve, and I was having terrible back issues, and I'd been referred to a neurosurgeon, and sort of went through all my history, but he ended it by saying, "Well, I wouldn't waste my prodigious skills on someone as fat as you." And I said, "Well, um, I'm having weight loss surgery." He said, "Well, don't bother doing that. That's not going to help anyway." Yeah, and it was like just one bias after another. Yeah, and it's like so. Yeah, and I think we can look at people and go, "Oh, they smoke, so I wouldn't waste surgery on them." But then you have other people, other surgeons that go, "Oh, you're fat. I wouldn't waste my prodigious skills on you to try and fix your back." Um, you know, Thankfully, I had my weight loss surgery, and I found an amazing neurosurgeon that did fix my back. And it was just, I guess for me, I tend to look at those sort of bias opinions when they're so rigid and go, there is a person behind that.
Yeah, there is. And I think medical professionals are also human beings, and they are also guilty of having inherent biases and prejudices. And it's sad to hear your story there around the reaction you got from your back surgeon. But I'm hopeful that the tide is turning,
Mm.
and that biases are being managed, and that understanding is enhanced as we start to identify more and more of the specific genes involved in why some people have got trouble with their weight and why other people don't, and why some people find it very hard to lose weight and other people find it easy to lose weight, and all of that genetic basis has really been studied in a lot of detail over recent years, and it's really challenging those biases. And I think as time goes by, we'll have less and less of those offhanded, unhelpful judgment comments that really have a negative impact on patients' psyche, don't they? It really, these offhanded comments that are made often carelessly without a lot of thought behind them by the doctor have such a long-lasting negative impact on the patient that they never forget it. And I think we've got to be very responsible as medical practitioners not to make those offhanded comments, especially when they're uninformed, they're prejudiced, they're not substantiated or supported by any scientific literature, and be careful around making them. But you're right. Obesity is just another genuine medical condition like anything else, like inflammatory bowel disease, like epilepsy, like asthma, like a whole stack of medical problems that are genetically based and they're lifelong. And morbid obesity is the same. And so we need to remove the bias and the judgment and the prejudice from the management of that medical condition, in the same way we don't apply any bias or prejudice against people who might come into our office with Crohn's disease or ulcerative colitis, which are other chronic medical conditions.
Yeah.
Um, I think one thing that you probably your neurosurgeon trying to defend him in part may have meant is not so much I don't want to waste my skill set on someone who's fat, but more what it should have been is an education around saying to the patient, your current body weight does increase your risk of complications if we do the back surgery now. If we were able to get 20 kilograms or 30 kilograms off before we did the back surgery, that would lessen our risk of complications from the back surgery, and it would improve the durability of the back surgery in terms of alleviating your lower back pain or your sciatica. So what we should do is make you aware that one medical condition, the obesity, is affecting the management of another medical problem, which is the back. And therefore, to properly manage the back, we need to manage both. And
Yeah.
that might mean sending you off to see a bariatric surgeon or sending you off to see a bariatric physician or a dietitian or a general practitioner and have a discussion around specifics of getting those 20 or 30 kilograms off, whether it's with the use of Mounjaro or whether it's with the sleeve gastrectomy done before you have your back surgery, like it sounds like you had done in your case, so that you can get the best possible outcome for your back, which is the condition you're seeing the back surgeon for. So I think
Yeah.
if it's delivered in a sense of non-judgmental education, that's great. That's appropriate.
Yeah.
But if it's an offhanded comment that's to suggest that you've got some personal flaw in your character that's led to you to be overweight, and as a result of that personal flaw and the overweightness that's risen from it, I don't think you're worthy of my skills as a surgeon. There's no place for that kind of communication style in modern medicine.
Yeah. 100%. Dr. Craig, if someone is thinking about going down the path of uh, weight management surgery and they watch this podcast and go, I like Dr. Craig, how can they get in touch? What's the process?
Well, probably the first thing, the simplest thing is jump on our website and have a look. There's a lot of information there about the surgery, about the medications, about the program that we offer. And that website is at oclinic.sydney, oclinic.sydney.
And we'll put the
Or
link
send
in.
us an email, give us a phone call. So our contact details are on the website, but we're in the Crow's Nest, which is just on the northern side of the Harbour Bridge, very close to the centre of Sydney. And our clinic is right next to the Mater Hospital, which is our main hospital that we provide treatment at. And our number is 02 for Sydney, 8197 9595. I'd be only too happy to hear from any of your listeners if they want an opinion or have a consultation or even a second opinion. If they've seen another surgeon, they want to just have another opinion like we often do with medicine, then that'd absolutely be more than welcome to reach out.
And there's nothing wrong with getting a second opinion, is there?
It should be encouraged. Nothing wrong at all.
That's something that I've come to realize because I've had a lot of surgeries, and for me, I like to get a few opinions so that I can make the best decision for myself.
And you should, and there shouldn't be any stigma associated with it. And I very much encourage patients to tell me if they're coming for a second opinion. Fantastic. Let's have that chat. Let me tell you what I think, and then you can go away and have a thought about it all. And it may only confirm that you were on the right track, or it might give you some extra options that weren't presented to you previously, or it might give you an enhanced understanding of how to move forward and get the best possible success. So a second opinion should always be encouraged.
Great. Awesome advice. Thank you so much for joining us.
My pleasure, Damien. Thank you for having me.
This has been great.
You're most welcome anytime.
Just hit pause.